Okay, good morning, everybody. Thank you so much for joining. If you're new to Zoom, you will see that I did put a message in the chat session. If you currently have more than just yourself watching this webinar, if you could put how many people are in the room watching with you. We're trying to keep track of how many are on this call, and would love to know who's present with us. I'd like to just start off by asking, can everybody see on their screen our slide presentation? Wonderful. And then also, just to start this webinar, I'd like to ask, if you are not speaking or asking a question, if you could please put your phones on mute to make sure that we don't have any background noise during our speakers. Okay, and we'll get started here. So this is the Iowa Healthcare Collaborative Opioid Guardianship Quality Improvement Project. This is our second of 3 webinars that we are providing to look at this very important opioid crisis that is happening not only in Iowa, but across the nation. So welcome, everyone. Our facilitator today is Dr. Brian Isitz. He's a professor at the University of Minnesota College of Pharmacy. Brian is a practitioner, educator, and researcher. He is a former health policy fellow at the Centers for Medicaid and Medicare Services at CMS Part D MTM program and at the CMS Innovation Center. Brian serves as a medication use quality improvement advisor for Iowa Healthcare Collaborative. So welcome, Brian.
Thank you, Jennifer, for the introduction. And it's really exciting to be here today, because as we reflect upon our journey, we're at about the midway point or halfway point of this opioid guardianship quality improvement initiative. And it's pretty exciting as we see what's happening. We're really beginning to make a difference and leading the nation. And if I could, there's one individual on the line that has their line open. If they could put their line on mute, it sounds like we're getting some back feedback. We've got music. No, don't put us on hold, please. That creates music. All right, Jennifer, I'm going to keep speaking while see if we can overcome that feedback and being on hold.
Yes, I'm trying to find words.
Okay, all right, great. So some of the new developments are the fact that the Joint Commission just 2 days ago released put a press release out announcing the implementation of new and revised pain assessment and management standards effective January 1 of 2018. And what's interesting as we read through these, it's exactly what we're doing. Here we are. We even beat the Joint Commission to the punch here, right? Asking to.
Brian, can you hold on? I'm going to mute everybody, and then I'm going to unmute you.
Okay, great.
Okay, Brian, can you try to talk again?
Great. Testing. 1, 2, 3.
Wonderful. Okay, you can go ahead.
Great, thank you. I feel like I was speaking to my family at home. No one was listening. All right. So really, it's the Joint Commission here. They're released these pain management requirements for January 1st, and it's succinctly stated. It's going to include the following new requirements: identify a leader or leadership team responsible for pain management and safe opioid prescribing, involve patients in developing their treatment plans and setting realistic expectations and measurable goals. You don't know how all that warms the cockles of my heart. Promoting safe opioid use by identifying high-risk patients, monitoring high-risk patients, using the prescription drug monitoring program, and conducting performance improvement activities to increase safety and quality for patients. That's exactly what we're doing here, and it's so exciting to see what's transpiring, because we're seeing of the 24 cohorts we have into colleagues working together that are in close proximity. Similar sized hospitals. We've even had one of the facilities ask us to help them to develop a charter, if you will, a written document to help solidify this commitment. So this is pretty exciting. And here's why we're here today: to ensure patients on opioid therapy have treatment plan goals of therapy with care plans if adjunctive opioids are needed and for decreasing opioid use. And it's for all of us. I mean, hospital-based community leaders, providers, pharmacists, dentists, it's every one of us who lives and breathes and works in communities, because it is about one of the most common elements of our health, and that's functional status improvement. Next slide, please, Jennifer. And while Jennifer moves, this is the graphic depiction of where we are all over Iowa. Fairly well distributed, very, very interesting to see this graphic picture. This is kind of where we are from the map. And let's go to the next slide, which shows the participating hospitals. Here we have really lists out in the various medical centers that are scattered across the state. These are really being looked at. Folks are watching us because we're doing something that's pretty neat, pretty innovative, and what's really needed to help us begin to address the front end of appropriate use of opioids when needed, as well as some of the work of what we do in our communities for those who have succumbed or have of the addiction, as well as how we work together as communities. The owners of the project, here are some of those. I'm sure many of you are on the phone. I thank each and every one of you that are really leading the charge here for this initiative. Jennifer, this is pretty exciting, don't you think?
Yes, I think it's very exciting, and I just want a big thank you to everybody who's really stepped forward, because again, this was a voluntary program, and I think that when we look across our media and we look at what's going on in our nation, we really need to get our heads out of the sand and start to address this now, looking more upstream opposed to let's wait till it really attacks us, which you'll hear today from our speaker. We are having a problem now, but more things are to come, and you know, we could really make history here to avoid what is projected.
All right, so moving
forward,
please.
Yep, moving forward here. So let's go ahead and do a poll. I know we have a lot of people on the call. We have a lot of people that are sitting in conference rooms with their opioid group, which I think this is wonderful. But we do have a few questions that we would like to ask. So I'm going to go ahead and put some poll questions up. If you could go ahead and take the poll, and then we can review. We have about 10 seconds left. Good job. Ooh, you guys are good at voting. And if you have more than who's on the call, you can go ahead and type that in. So if you have a pharmacist present, a provider present, a nurse, if you just want to choose one and then go ahead and put everybody else into the chat section. So if you go ahead under the More tab, you'll find the chat session. Okay, I'm going to go ahead and show this poll.
Successful, Jennifer. Yes, we have. Who is on the call? 38% pharmacists, 29% nurses, 25% other. That'll be interesting as we figure out who those are joining us. And well, of course, very much welcome, and that reinforces the need for all of us in our communities working together to be a part of this special cohort. All right, Jennifer.
Okay. Wonderful. And if you have somebody under the other, please go ahead and put that in the chat section as you find time to do that today. We really do want to know who is on our call. So we'll go ahead and move to our next question here. And our question is, how many opioid team meetings have you had? This does include conversations with 2 to 3 people, because we realize this is new that you're developing this team. So if you could just give a rough estimate of how you're meeting, have you started meeting? Are you just had one team meeting, but you've talked with multiple people? Those things all count. So we'll give about another 20 seconds on this one. Okay, let's go ahead and share these results. And Brian, what do you think of this? This is very impressive.
Well, 2 to 5 is at 63%, and more than 5, 29%. I can give that, Jennifer. That's, as you like to say, a good woohoo.
Yeah, I'm very happy to see this. And, you know, I think that not only having the big team together, but conversations between 2 to 3 people, a lot of good stuff happens during those conversations. Okay, we'll move on to our next poll. Where are you currently in the use of your discharge treatment plan for patients discharged on opioids? Starting to develop, using in sample populations that you are choosing for your sample, implemented. Okay, we'll give it another 10 seconds here. We still have some replies coming in. And I'm going to go ahead and share that result. And I think, Brian, this is exactly where we thought that people would be at this point with the big workload coming here in the next couple of months. We've formed our teams. We're starting to look at what this process is going to look like. We're gathering our resources, and I'm very happy with the result.
Yes, and you know, it's on a side note, I just want to share the fact that is I have a geriatric practice, and I'm actually using these same medication management treatment plans with some of my patients in my nursing homes. But also, I want just without sharing too much HIPAA, my wife is going for some surgery soon at the Mayo Clinic, and I'm going to use one of these for called an opioid sparing advanced directive for her treatment plan. So this is something that we all can use, and the fact that we're working on this together, that's our concentration over the next 30 days.
Okay, wonderful. And then our last question for this poll is, have you accessed Innovation? Your answers are not yet. I would like a training session on how to utilize Innovation. I'm on Innovation, but not active yet. And I'm on and active on Innovation. So you're actually looking at the resources, you're looking at the questions. As you're filling this out, I want to let you know that if you are marking I would like a training session, please contact me, because we do want to get everybody, including your team, on Innovation. This is a great opportunity that we have to actually speak with each other through a social media platform that says, hey, we're working on this. Where has anybody got on this? And I know that we have one question out there that nobody has answered. And we do have to pull together, because that's how we're going to create a huge wave and huge rapid improvement here. So I'm going to share the results here in just a couple seconds.
Hey, look at that, Jennifer. Wow. And let me just put in a plug for Innovation, because I know if this is very important at the national level, at community of practice. And I know how some of you are feeling. It's like, oh no, one more social media platform to check. And it's important to realize that this is dedicated to us and what we do. And it's not broadcast across the general public. And it helps us accelerate our progress. So I really want to speak highly for Innovation. So good job, Jennifer.
Wonderful. And moving on, I would just like to share, I am putting together a Innovation demonstration. I have sent out to all the owners how to get on Innovation and how to get to our medication safety section. But what I'm going to do is I'm going to show you how to actually get into the library. I will send this link out at the beginning of next week, but it's a way that people on your team, you can just send it to them and they can watch a little video to say, oh, this really is simple. It just takes a couple minutes to get on. And if the person on your team is working on a certain part of your project, they can reach out to others that are also working on those projects. So that is one of the up and coming things that you will receive here in the next week. Just as a reminder of what we're actually looking at here, and I know that when I'm talking to many of you, Brian had mentioned the charter. I know that we did have someone ask for that, and I think it's a really great idea to do that, because there are many rabbit holes that can be happening with this project, but this is what we are actually looking at, the opioid therapy treatment plan. number of patients discharged from a hospital on opioids with patient-specific goals of therapy at discharge, and that's over the number of patients discharged on opioids. This is a self-reported measure, so it can be sampled. You can choose your sample, but I think when we look at this, what we're finding, one hospital started to look at their population, and they found out that 75% of their patients were discharged on opioids. So we are going to find a lot of information that will be helpful while looking at this one measure, but remember, this is the measure that we're looking at. The other one that we did add that is not a normal HIN measure is the stat naloxone administration in the ED. So we're looking at the number of episodes when a reversal agent is administered to emergency room patients over the number of emergency room patients. You know, Brian, we have been looking a long time at stat naloxone administration in the inpatient population, but what we found with our last medication safety project was INR greater than 5 is we really need to see what's coming into the ER, because that's coming to us also from things that we're prescribing not only in the hospital but outside of the hospital. So this, I think, was a great measure to show us some really important data when we looked at INR greater than 5, and I also think this will be great for our project.
Absolutely.
So Brian, I'm going to turn it over to you to just kind of talk a little bit about the treatment plan.
All right, great. Thank you very much, Jennifer. And so this is our focus here. We want to get what is a treatment plan. And for those of you who were on the first webinar, you kind of heard my general approach is that we have, as we do these pharmacotherapy assessments, is what we call it, to understand all of a patient's drug-related needs, we need to set goals of therapy for each of the medical conditions for which they're taking drugs. It's amazing that we haven't done this sooner, because we have goals for everything else in life, for where we want our retirement, and for what do we want to do with our family and our grandchildren. But you know what? We take drugs, and it's almost like nonchalant. I don't know what they're supposed to do for me. Well, this is what our time right now is. It's for all medications, set these goals of therapy so we can understand our progress towards meeting those goals. If I compare it a lot of times to your visit to the dentist. Your goal is not to have cavities, and so your gum disease doesn't recess. And you get done, and the dentist says you've achieved your goals of therapy, and I call that an attaboy care plan. You've done really well, and you feel good about yourself. Well, that same feeling can be applied to the use of medications. So it's a comprehensive and integrative care plan to ensure effective and safe use of opioids when indicated as adjunctive therapy. They're established in shared decision-making with patients and families to optimize the use of non-drug and non-opioid therapies first. We have to make sure goals of therapy are measurable, realistic, and patient-specific. We have traditionally used a pain scale, 0 to 10, pain being 10 being the worst pain you've ever encountered. However, we see this evolution now to a comfort scale, where 10 is the most comfortable I've ever been, and 0 is the least comfortable, focusing on the positive rather than the negative, which I think is brilliant. It's really intended to improve function and quality of life, improve these comfort levels, reduce pain, limit opioid use if and when needed to the lowest dose for the shortest amount of time. And again, they're objective, patient-specific measurements to guide step-down therapy with scheduled follow-up evaluation at day 2 or day 7 for sure, because we know that if you're on opioids after 7 days, your chances of being addicted go up dramatically. And so we've actually put one of the resources we put together is a sample opioid treatment plan for an individual who's coming in for gallbladder surgery, for instance. And so we have many of you folks are working with some of your units, and we want to really make sure we push this forward, because this is something that is so desperately needed across our nation. Next slide, please, Jennifer. Because this takes us to an evolving paradigm shift in the use of opioids. We've had this in our medical training, this pendulum switch has shifted back and forth, where first we don't want to use opioids, and now we use as many opioids as you can. Pain as the 5th vital sign. Over the time, we've underestimated the importance of setting goals of therapy. You know, we all have seen the days where you go in for some procedure, they give you a bottle of 100 Vicodin and send you home. Well, 2 weeks later, it's a little late, because now there you are, you're on the road of substance abuse. Focusing on comfort and functional status improvements, the positive again rather than the negative of pain. The importance of assessing prior patient experiences and opioid naive status. I mean, think this is critical to as we go into shared decision making. It's like, well, Mrs. Jones, tell me, have you had any other procedures done, problems you've taken when you, if you've taken any opioids? Maybe they took codeine on after dental surgery and they had hives, or they have had taken Vicodin and they had a bad experience because they didn't understand the prescription directions. For instance, take 1 to 2 tablets every 4 to 6 hours as needed. What does as needed mean? They took 2 tablets every 4 hours, and 2 days later they had to be rushed to the emergency room. This idea that it's not happening in my backyard. Well, the good news is that in Iowa it is in our backyard, but not as bad as Ohio and Pennsylvania. But we don't want to wait for that day. We do recognize the fee-for-service prescribing dilemma. During the fee-for-service days, you see a patient every 6.2 minutes, and they feel robbed if they don't walk out with a prescription. Those pressures and expectations are changing, and we're going to help change those as well as we move to value-based financing, as well as working with our communities to change the expectations of how we improve functional status. And then this unrealistic patient expectations in the absence of shared decision making. I have pain, I want opioids because I think that's all there is. Well, there's not anymore. We know what the clinical practice guidelines give us a long menu of other options that are just as effective, if not more so, than the immediate use of opioids. And then we have our good friend, the HCAHPS, Consumer Assessment Health Provider Survey. In the hospitals, there's 3 pain items. HCAHPS item number 4, did hospital staff do everything possible to help you with your pain? They're implying right off the bat that pain, that you have to get to a 0, when that may not be the case. Realistically, I want to move from a 5 to a 3 and I can stop taking opioids. I don't have to get to a 0, because if you try to get a 0 to a 0 with opioids, we all know what the consequences are. And even CMS has realized the drawbacks to the HCAHPS pain domain. And they have decided to exclude the 3 HCAHPS pain scores from future value-based payments. And with that brief introduction then and overview of the subject, I'm going to turn it back to Jennifer.
Thank you, Brian. Well, I'm very excited this morning to introduce our speaker. Melissa Springer received her Master of Science degree in Clinical Psychology in 1995. She holds an International Advanced Alcohol and Drug Counselor certification. She also, for the past 20 years, has worked with adolescent and adult patients presenting with multi-occurring conditions. Melissa serves on the Iowa Board of Certification Advisory Council and Board of Directors. She is a member of Chemical Dependency Treatment Providers of Iowa. Melissa is currently the coordinator of Mercy Turning Point Treatment Center, including medication-assisted treatment services, and is the clinical opioid lead for Mercy Medical Center Dubuque. And Melissa, I'm going to unmute you here real quick. And once again, I will unmute all the lines so you can have questions, because I think you're all really going to enjoy Melissa's presentation here. Okay. Melissa, can you put in the chat what number you're calling from? I'm going to try to call.
Yeah, I'd go crazy.
Yeah, we're still getting a lot of noise. So, Melissa, if you could go ahead and tell me what phone number you're calling in on, then I can unmute you.
Sorry, all my phone.
Sorry for the, oh, Melissa, can you, no, that's not right. Melissa, can you go ahead and try to talk to see if we can hear you?
Hello, can everybody hear me?
Yes, perfectly, thank you.
Great to be with everyone this morning as we work together on our opioid quality improvement project. The opioid epidemic is a global threat. It's a crisis for our nation, and it's been plaguing Dubuque quite hard and other places in the state of Iowa. As Jennifer mentioned earlier, you know, we've been notified by federal officials that the peak of this epidemic will hit Dubuque in about 5 years. And that's hard to really wrap your head around, considering that we've lost about 25 of our residents in the past 2 years here already. Those are families that are burying a child or in one case, children. In April of 2016, we actually had 7 deaths here in Dubuque in 1 week. And there was much public outcry, mostly directed here at Mercy Medical Center, Dubuque. Many of these patients were known to us. They'd been in our ED setting. They'd been in our psychiatric unit. Perhaps they were in our treatment center at one point. And we're a small enough community, about 58,000, that, that was quite significant to have that many deaths in 1 week. At that time, Mercy, we knew that we couldn't do everything. We knew that the hospital could not do everything, but we knew we wanted to be a leader in terms of helping to develop community solutions, and knew that that was going to take the work of various sectors across our community and the state and even federally. At that point, last April, we decided to develop an opioid response team. Initially, that team had 3 or 4 members. To date, we have 30 individuals that present to our opioid response team. Next slide. This epidemic of opioid misuse, overdose, and death is really multifaceted. It's a crisis that requires partnership across all sectors to respond with effective health care and public safety strategies. Next slide. The team includes all sectors and leverages the skill sets and input of the diverse membership. And I won't read through all those that are on the team, except to mention that we do have city, county, state, and federal leadership. And so that helps us to leverage the skill sets of all those members of that group, and also helps us to move forward and develop solutions quicker than we might have been able to otherwise. I do want to note that more recently we had a mother who did lose her child to opioid overdose join our team, and that brings a different voice to our table, and a very important voice at that. Next slide. The opioid response team initially came together to work on naloxone access. At that time, the state did not have a standing order. The state epidemiologist did not have the standing order in place for naloxone, and we really couldn't wait. We wanted to have that medication available for our law enforcement and persons in a position to assist in our community. The law was in place, just not the standing order. So our medical director, Dr. Tom Boxleiter, here at our treatment center, was really the physician champion for naloxone, and he worked with our Mercy Family Pharmacy to develop a collaborative agreement for the training and dispensing of naloxone. And he was agreeable to do this under one condition. He didn't want us to just hand out Narcan to anybody without equipping them with the knowledge of how to effectively identify an opioid overdose, and then how to feel confident in administering that medication. So once we had that standing order in place, kind of ahead of the state standing order, we realized that the county, and talking to the county board of supervisors, the city, and talking to city officials, they did not have funding in their budgets for naloxone. So we did go to our Mercy Health Foundation and request a $20,000 pledge. And talking to the city and county, they said that maybe within 2-year budget cycles, they might be able to work that in. Well, we didn't have 2 years to wait. We were already losing so many people in our community. And we know the United States Department of Health and Human Services talks about 3 keys to the crisis, to the opioid crisis, and that is making sure a community has timely access to naloxone, Narcan, and that law enforcement is equipped with it and using it, educating physicians in safe opioid prescribing, and also having medication-assisted treatment available in the community. So again, our opioid response team work was very closely focused on that naloxone access, and I can tell you, to date, we have trained using 2 community education nurses, our entire police force of 109 police officers, our sheriff's department, which encompasses 75 deputies, drug task force, and jail administrators. And the majority of them are now carrying that medication. They wear it in a Velcro wallet around their ankle, a 2-pack nasal Narcan, some rubber gloves, and a pocket knife they wear around their ankle. And although it's not mandatory for them to carry per their policy, the majority of them are choosing to carry, not only so that they have that opioid antagonist to help reverse an overdose, as they're oftentimes the first to the scene, but also so that they can help protect themselves, because we know that Much of the heroin coming from Chicago to Dubuque is fentanyl-based or fentanyl analogs or carfentanil even, that can be very dangerous to even the law enforcement and EMS officials and our ED teams. As our opioid response team moved forward, we contributed to some draft legislation on Good Samaritan laws and prescription monitoring program usage. We did some advocacy at the state capitol. And we did a lot of work with community outreach. So we know that building awareness, having education and engagement across all stakeholders, including patients, providers, pharmacists, families, and communities, that broad community education is critical. And we held a town hall meeting with 650 in attendance, had an opioid listening session with senators, and more recently an opioid listening post where we brought in state and federal officials to talk to our community members so that they feel like they're having a voice, which is very, very important, especially for those families that have lost loved ones or those that have loved ones that are still in the thralls of active addictive disease. We created a substance use disorder resource drop card. This is a drop card. It's front and back paper that has all of the resources in our area specifically related to substance use disorder. And this is put out with all of our syringes that leave our pharmacy. It's used as a teaching tool for pharmacists as they work with patients. And also law enforcement use this card anytime they're in the field when they go to a scene where there's a substance of misuse. And I will just say, I know we have several pharmacists on the call. And in the work that I've done over the past 15 months with many physicians and healthcare teams, I just want to stress the importance and the role of the pharmacist. Many physicians have felt quite burdened when you talk to them about obtaining their DEA, ex-DEA waiver to prescribe buprenorphine, or you talk to them about safe opioid prescribing or using even registering for the prescription monitoring program and using it consistently and proactively. But the pharmacists have been very enthusiastic, very eager to assist. And so for all of the hospitals on the line, do not forget the role of the pharmacist as you use them as a springboard to reach your physician groups and your other healthcare team members. They've been extremely helpful at our end, not only with the Naloxone collaborative agreement, but also in patient teaching and distributing the substance use disorder drop card and encouraging patients who are coming in filling extensive prescriptions for narcotics, encouraging them to seek treatment, making those referrals, saying to patients, this prescription's for 50 Vicodin, I'm going to give you 10, and then you can go back through your doctor if you need, additional pills. So I just really want to emphasize the role of the pharmacist in this work, and it can be very, very helpful. We've done a lot of work to internally do our healthcare teams. We wanted to make sure that, we were doing all this community education and outreach and awareness, but realizing that we had disconnect right within our own walls, that our own emergency department team didn't know what we were doing in our outpatient substance use disorder treatment program and et cetera. So we've done lots of detailing, not only to the ED physicians and healthcare team, but through all the medical floors. And not only to physicians and not only to nurse practitioners and hospitalists and the nursing team, but also the dietitians, the chaplains, the social workers. This has all been very important to make sure that all 1,300 of us here that work at this hospital know what we're doing, with the idea of reverence in mind, that we honor the sacredness and dignity of every person. I mean, it's really inherently necessary as we look to reduce opioid harm and we promote people-centered care within our organization, that we have everybody with the same mindset. And Joyce McDermott, who's on the call today, who is our lead here at the hospital with this Guardianship project, and myself, we've done much work just breaking down stigma, and making sure that we have everybody on the same page as we continue to be now a little bit more proactive in the work that we're doing here. Just briefly, we did start offering medication-assisted treatment here in December of 2015. To date, we've treated 125 patients. 80% of those patients that presented here for IV heroin misuse started out on prescription opioids, and I think that's a very overwhelming statistic. Initially, many referrals to our MAP program were for IV heroin, but current referrals are really now we're seeing referrals from primary care physicians for patients who have taken narcotics for 25 years. We just had a referral of a gal who had taken morphine suppositories for 25 years, and her physician wanted to get her off of those, and we're using Suboxone therapy to do that, and she's having a really good response to that. And quite frankly, the majority of the patients have had a positive therapeutic response to the Suboxone therapy. It curbs their withdrawal, it keeps cravings at bay, but it also increases dopamine in the brain, which is very important when we're asking patients to follow through on treatment plan goals and this sort of thing. Let's see, just kind of as we work in closing here, some of the work that we've done here more recently is just as Brian was mentioning, where we're working with our pain committee to look at how we monitor and have meaningful process with patients about pain at the bedside. So not always focusing on their pain level, but more on their comfort level, and providing them different comfort measures that they can use, and non-pharmacological options such as repositioning, hot and cold meditation. We even talked yesterday with our pain committee about bringing back the good old comfort cart, where we have squishy balls and decks of cards and lip balm and different things that people can use to just help to self-soothe. We've also talked with our team about writing actual meaningful pain goals on the whiteboard in the patient room, and having the opioid therapy treatment plans, of course. So communicating those pain goals, documenting those goals. What's come from our nursing teams on like the surgical floor and such is that, you know, they're doing some of these things. They're not always documenting that they're doing it. So we want to make sure that we're doing good sound documentation around this work. We're also monitoring the Narcan use in our ED. We're using some essential oils in our surgical services area, and it looks like that will go throughout our house here, that will be an option for patients. We have some opioid discharge instructions that we're finalizing by the end of this month, that may be in our electronic medical record or maybe a hard copy, but it's really, what is an opioid? How do opioids work? What are the risks and side effects from taking opioids? How do I safely store and dispose of my opioids? And then non-pharmacological things you can do to relieve your pain as well. We've currently worked with our chief medical officer at our medical associates clinic to develop a policy related to prescription monitoring program use. We didn't have a policy on that. So the physicians that work at our medical center are contracted with us through the clinic next door. So that clinic now will have a policy in place that says at the very least, the physicians will be registered for that prescription monitoring program, that they will be checking it when they prescribe opioids initially, and thereafter when they have concerns or red flags are raised. We will be doing some provider education in the fall, so that when physicians are more actively using this prescription monitoring program, they then know what their resources are locally when they do have concerns or red flags or need to taper somebody off of opioids. Because we want to wrap resources around physicians. So again, they don't feel burdened by this, and yet we're still doing very good clinical sound work. So again, it's nice to work with all of you, and appreciate the opportunity to visit with you. And again, I just want to leave you with that concept of reverence, that we honor the sacredness and dignity of every person that we work with, and that's what we communicate from the top down, from our chief nursing officer all the way down to the housekeeper in the medical center, that's our mindset in working with patients who present either post-overdose or an acute withdrawal or needing stabilization for their brain disease. So thank you. Brian and Jennifer, back to you.
Like things that patients don't necessarily think, like this is something.
Until Monday.
Very good. Thank you, Melissa. Jennifer, are you on the line?
Yeah, sorry about that. So I have put everybody over to unmute so we can hear everybody at this time. And Melissa, I just want to thank you for sharing. Every time I listen to your story, I feel like the work that you've done is going up and beyond over your job. And I know that I can hear the passion and the love that you have for your patients. So does anybody have any questions for Melissa? I hope that you've all been taking notes for all the things that they've been doing, because Melissa, I think when we talked, you said you guys have started working on this 14 months ago. Is that correct?
That is correct.
So in the short period of time, you have accomplished miles of work. And what I hear you saying is it was from you bringing the right people to the table that, you know, could take a piece of each little piece of the puzzle to put this all together.
That is very helpful. And I know our hospital system, we have 99 hospitals in 22 states, and we treat 30 million people across those hospital system. And we are starting to see our opioid response team modeled in those other locations. And I think it's kind of a simple thing to do. We put out some lunch. We have the sheriff, the police chief, our own team sit around the table. And it's been a model that's been very solution driven.
Okay, wonderful. We do have a few questions in the chat section. One of them is, how have you engaged your local pharmacies in Dubuque?
One thing that we've done, we had the Iowa Pharmacy Association did come to Dubuque and do a breakout session that we had an opportunity to speak at. So outside of our own Mercy Family Pharmacy and our internal and retail pharmacy, that was very useful. And again, like dinner was served, we had it in a community location, and we had pharmacists from the surrounding area, so not just Dubuque, but Macokota and Guttenberg and all the whole surrounding area in our catchment area. And again, there was a lot of energy and enthusiasm and pharmacists being very willing to help. And so I think that was very helpful. You know, obviously we've engaged our own, you know, pharmacists here at the hospital, but in terms of working with local pharmacies, also with discarding opioids, working with local pharmacies to have them have the ability to take back controlled substances. So when patients want to discard of unused opioids, instead of putting them in their medicine cabinet where their high school children can get a hold of them, taking them to one of the drugstores, one of the local pharmacies in town that now have a narcotic take-back box. So that has been, that's been very useful as well. I see a question about essential oils that are used in the surgical department. Currently, we're using lavender, and we are using peppermint. And I believe that there's some plans to move forward with some other options with that.
Okay, and then one more question. Could you share
the
your
prescription?
PDMP?
Yeah, the prescription monitoring program policy is currently being drafted by Medical Associates Clinic here in Dubuque. I have it in draft form. It is something I probably can share, and I could get that to Jennifer and she could get it out to the group.
That would be wonderful. As soon as you get that, that would be wonderful, and I will share that out on Innovation. And we have a couple more questions. Do you need a doctor order to use essential oils?
I do not believe we need a doctor's order to use the essential oils policy. I believe there's a policy. Again, this is kind of early stages of use. We do courage and innovation projects here, research projects, and our surgical services area is just kind of getting started on that with the essential oils. And I would imagine it's really going to take off, and that probably will spin into a formal policy, potentially a doctor order, and other oils that might be able to use. I know Mayo Clinic, I see Covenants using lavender, ginger, and peppermint. Mayo Clinic uses lavender, ginger, peppermint, and tangerine. We can most definitely share our resource drop card. And
she had shorts and you know, like.
And probably as we move forward with our essential oil use, we could share some of the more specifics about that with the group.
I do see that Covenant has answered Erin. Erin, could you put a post on Innovation about how you use the lavender, ginger, and peppermint? And if you also have a policy for that?
For somebody from the scene, something pretty drastic.
And Erin may be on mute, but I can look back through these comments, and then what I'll do is we can just start a discussion on Innovation over that. Okay, and Erin says, yes, she's going to start that discussion on Innovation. Thank you so much, Erin. So, Brian, I'm going to let you wrap this up. I know that when you and I spoke with Melissa, we're like, we could talk for all day. But I'm going to let you go ahead and take it over.
Right. Okay. Well, that's this is pretty amazing, and just to see the response, just by just the organic interest going forward, and really, it's using all the other tools we have that are now in clinical practice guidelines before we use opioids, and how it's exciting how we're putting these together. So, Jennifer, let's go to the next slide, please. So here's how often do your providers or other hospital staff access the prescription drug monitoring program database prior to providing opioid prescriptions? Jennifer, before I go on, maybe we should remute the cohort.
Yep, I will get that done right now. You're going to be muted for just a second.
Okay, great. Thank you. Please hold.
Okay, Brian, I think
right.
you should be good
Thank
to
you.
go.
We're back on. All right. So as we can see is that how often you use this, 14 of our colleagues are very rarely, and 2 never. And that's really, I mean, it's what we found is that this is really an integral piece. We've talked about the front end, making sure we talk to patients about their experiences, their opioid naive status. But now what happens for those that are already down the substance use spectrum? All right, is that how do we identify those people, get them more readily into treatment? So this is the subject of our next presentation. So if you would, Jennifer, advance. It's my honor, distinct honor, to introduce our next speaker, a good friend and colleague, Dr. Randy McDonough, who's co-owner of Towncrest Pharmacies in Iowa City. You can read all his bio, but let me tell you the real story behind Randy. He is really one of the foremost pharmacists, not only in Iowa, but across the United States. I've known him for a very long time. We've worked together in terms of establishing treatment plans, goals of therapy for patients for all their medical conditions. He is a leading national expert, also serves as on the board of trustees for the American Pharmacists Association. And Randy, we'd like to share some of your insights on the use of the prescription drug monitoring program. Dr. McDonough?
And Brian, if we can wait just a second, I need to get him unmuted as well.
Okay, great. And while she's doing that, Randy, you let us know when you'll get a hi sign from Jennifer when she has unmuted your line.
Okay, we can go.
All right, you can hear me okay, Jennifer?
Yes, thank you.
Okay. First of all, thanks a lot, Brian, for the introduction. And I first will say that I wouldn't say that I'm an expert on the PDMP, but I'm a user of the PDMP. And as I put this presentation together, having a background in academia and leaving academia to become a practitioner, I'm also an evidence-based person. So I try to make sure the information I provide has the backing. In addition to that, I did call the Board of Pharmacy and talk to Terry Witoski, who's very helpful regarding the PDMP. So a lot of this information is a compilation of a lot of different facts that are out there. First of all, what is a PDMP? It's a tool that can serve to address prescription drug diversion and abuse. Several functions that it serves. The patient care tool. I think patient care is the most important. You know, when we talk about the opioid therapy treatment plan or the discharge treatment plan, and then when I saw that question that popped up about how you engaging local pharmacies, that's something I think that we feel left out sometimes at a community pharmacy, that we're not getting that information. So we're left to fill the prescription, and we'll be monitoring the PDMP. But it'd be nice to know what goals of therapy are and how this should be managed. As we work up our patients, we try to gather that information because we realize that opioids are a high-risk medications. So we do this on our own, but it would be much nicer and I think much more effective for both of us if that information was being shared between the providers. Obviously, beyond the patient care tool, it is a tool to be used to help prevent drug diversion. It's also being used by prescribers to avoid drug interactions and identifying those individuals who might be drug-seeking behaviors. That's okay. You can go on. That's next. Go to the next slide. Thank you. As I was talking to Terry, and I think the thing that's been made very clear to us with the PDMP is that we got to be thinking about patient privacy. As long as the providers that you're working with is actively involved in the patient care, that is information that can be shared. And it's something that we really should be utilizing to help determine who might be a good candidate for opioid therapy. But at the same time, you know, if we are putting someone on opioid therapy and we have checked it, what are we doing passing that information on as far as the treatment plan onto the pharmacy? This is something that the board made very clear that it is protected. And so the patient themselves can't even access this without having the approval from the board. So the board would actually give them the information, but they can access this, and you can't not give that to them. And healthcare providers can only access the PDMP data that's relevant to their patients. Next slide, please. Next slide. So I talked about the effectiveness and the data that supports this. Looking at some studies that have been out there recently in one particular case, and then went from one case to a state to multiple states, but it did show that if you use the PDMP proactively, that it does reduce the amount of opioids that are being prescribed. So obviously, using this tool is a good way to identify who's a good candidate and who's not a good candidate. And then if they are a good candidate, again, do we have a treatment plan that's going to follow them as well too? In the next study, it actually shows within a state how it reduced the amount of drug abuse and diversion within that state. And then with the last study reporting with several states that it reduced the unwarranted prescribing and subsequent diversion of abuse prescription drugs within their state. So I think it's pretty clear that utilizing the PDMP proactively, it works. So next slide, please. The thing I want to make very clear is that it's very easy to register, and I'm going to show some slides as far as what it looks like on the web, on the page. It's easy to use when you do a request and look up information. Other features, as I was talking to Terry at the board about this, is she wanted to make it clear that with prescribers and on pharmacies as well, you can use agents. And those are agents of that prescriber of that pharmacy. And it might be a technician, it might be a nurse, it could be assistant. But these are individuals that have been identified by the prescriber or by the pharmacist that are people that can access. But remember, that person is accessing on behalf of that prescriber or that pharmacy. In the past, the Board of Pharmacy said you could have up to 3 agents per prescriber or per pharmacist. They have recently changed that now to up to 6 that can access the Iowa PMP under the registrant's authority. The other thing Terry wanted me to let people know is that they are really talking about future integration of the PMP within the hospital systems, and so that you can access that patient information within the workflow. So those discussions are ongoing now with the board, and they're trying to make everything more user-friendly and updating the application process. With the use of the agents, the prescriber, the pharmacist, we all can register online, but the agent, actually it's on paper. And you can access the form if you go on to the Iowa Board of Pharmacy, or if you just call the Board of Pharmacy, they can help you work through that process. It's just, I think, an extra precaution to make sure the agent is someone that is under the registrant's authority. Next slide. As I talked about, sharing of the PMP report, you can be shared with any other healthcare provider that's actively involved in patient's care. It cannot be released to the patient or anyone else, because we got to remember that this is confidential information about the patient. As I said, the patient cannot access the report. We cannot give the patient the report if they come to us. So we have to direct them to the Board of Pharmacy. It's not that they won't get the report, but the Board of Pharmacy is the one that has to give them that information. As far as potential issues, right now we don't have mandatory registration. But even if we did have mandatory registration, it doesn't mean it will be used, because we don't have a mandatory use requirement. There is a potential gap between the reporting of the data and when the information gets into the record. So it means that real time, you may not always see what was prescribed maybe just a day or 2 ago. It may take up to 2 weeks before that information actually gets into the system. So there is that possible gap. And then there's also problems if there's an error in the prescription record that's being submitted, and that error has to be corrected before it gets into the PMP record. These, I can tell you from our own experience, those errors are rare, and it's usually done automatically by the vendor. So we really haven't seen an issue with that, but it's just something to be aware of. Next slide. So these are the people who can access the Iowa PMP. We got the prescribers, the pharmacists, and then those agents that have been given authority to do that on behalf. And I say again, you can have 6 agents per pharmacist, 6 agents per prescriber. Next slide. This is what the initial site looks like when you go into the Iowa PMP website. And this is the login screen. So if you've registered, you have a login, and you just, hit enter or log in, and that will get you in. If you're not registered, all you have to do is unleave that padlock that you see to the left. You just hit register, and it'll bring the online registration that you can actually register yourself within that system. Very easy. We've done it. When I first got into it, I was intimidated. It was a very easy process. As I said, if it's an agent of the pharmacist or of the prescriber, then it is actually something on the web, and you can access to the web form. You can access that web form via the Board of Pharmacy website. Next slide. This is the actual home screen, and the thing I will tell you is where you're going to be spending most of your time is if you look at the top bar where it says request and alert. This is where you actually would, if you have a question about a patient and want to look at their record, you will actually do a request and then type that information when you get to that. If you have an alert where you have a concern about a patient, you may not be prescribing, but you may have found some information out. You want to prevent them from any diversion, and you want to send an alert to the group. That's what that function is for. Very helpful. I look at those alerts when they come out, and we have caught some people who have come to the pharmacy that were in that alert system. So it's something that if you suspect and you're concerned, utilize that information. Next slide. So this is where you actually would submit the information. So usually you're going to need the last name, the first name, the date of birth. And it has a default for a prescription range of 12 months. If you want a longer period of time, you just have to uncheck that box and then put in the dates that you want. And it gives you a pretty nice record of, it shows you all the pharmacies that they've actually been to, the prescribers that have prescribed, and you can actually see the dates that they've done that, so you can kind of put a picture together. Next slide. So this just shows you, once you get the information, it says, patient history request. You actually click on that. In the next slide, please. Then this is the information that you would receive as a report. This is something that we've printed out and we put into the patient chart. We have utilized our PMP not only when new patients have come in or people that are unfamiliar to us, and we want to just make sure we do our due diligence, but we also have utilized it for those patients that we've been taking care of for a long time, that we still have some gray areas about the use of their opioids, and just making sure that they're not going elsewhere and going into multiple prescribers or to multiple pharmacies to get their medications. This has helped us to develop our relationships with physicians and prescribers in town, where especially with some of our high-risk patients, we actually are sharing progress notes with one another over time, so we know what each other is doing to monitor that patient's progress with their opioid use and also with pain management. So overall, this tool has been just a very nice addition. It's something I think we need to be more proactive. We talk about upstream care. We talk about the pharmacotherapy plan. We talk about opioid treatment plan. All that stuff is very helpful for us to be proactive to really improve the therapy of our patients. But I think we got to work better as a team with pharmacists in the community setting, working more proactively with the hospitals and with the prescribers to make sure we're sharing information back and forth to really improve the outcomes of our patients.
Okay, Brian and Randy, thank you so much for presenting, Randy. And I have unmuted everybody again for some questions. Again, you can put questions into the chat, or you can also ask them now. Randy, we do have one question. Does the PMP go across state borders?
There are certain, if you go into the web page, there are certain states that you have access to, and you just have to click those states. I think it's like Minnesota, Kansas. I can't remember all the states, but I know Minnesota is one, Kansas is one. So there's an agreement between the states that you can actually access those states' records for that patient as well too. So it's not across the board with all states, but as states get these agreements, that's going to expand.
This is Michelle Weber at Horn Memorial Hospital, and I've got a question regarding the PMP report. You mentioned that you can't share that you know, come across that they've been accessing maybe narcotics or somebody else? I mean, how confidential is that information? I mean, we don't put it in the medical record, but if a provider does check the PMP and we see they're going elsewhere, is that okay to, you know, verbally say to them, you know, we checked the PMP, we see you're getting, you know, opioids from multiple providers. Is that okay to do?
We have, just so you know, when we have utilized the PMP and we've had a patient that we've had some issues with, we have, you know, told them that, and that's a good question, and I think it's a gray area, but we have utilized that information. We haven't shared it with them as far as giving them a hard copy, but just saying, you know, based upon the background checks that we do, we've identified that you're utilizing multiple places and multiple prescribers. And then at that point, we may even ask them, you know, we want to follow up with the prescriber and talk to them about this as well, too. So we try to make them as informed as we possibly can, but we don't share the report.
Thank you.
Okay, we have a couple. Randy, can you see the chat box?
I can.
Okay, did you want to talk about those questions?
Yeah, let me look at this here. So it says, I have a question about what information can be provided for us regarding physician use of this tool. Can you provide which physicians use it and what frequency? I don't know. And it's, from a community pharmacist perspective, I will tell you that I've always assumed that people are using it. Then I realize that that's not correct, because when the patient comes in and then we're not familiar with them, we'll go to the PMP and we realize, you know, if someone had looked at the PMP, they would have realized this was not a good candidate. The problem with that now, instead of being proactive and again working upstream to try to prevent an issue, now we're actually stopping everything and we're trying to get a hold of the physician. You know, we got the patient who's in the pharmacy waiting for some kind of an answer, and we're calling around trying to get that information addressed with the prescriber or with the hospital, the health system, whatever the case might be. So I think it's just important that you know, we start utilizing this more and encourage our physicians to use it more. You know, I've always said that, you know, when the physician starts getting this information and they start seeing it more frequently, I think they become more believer about using it. So I just think the encouragement of the prescribers to use this needs to be done. I don't think it's used nearly as much as it needs to.
Okay, well, perfect. Thank you so much for presenting, Randy. I think that when we just, again, you know, is it a blanket statement that, yeah, everybody uses the PMP? And then when we really look into it, like you said, Randy, you find people really aren't using it. So I don't know what you guys think, but I think it'd be a really neat Iowa initiative to say, let's start utilizing this and using this, even though it's not mandated. What do you think, Randy and Brian?
I totally agree with that. You know, it's a tool that's been out there for a while, and I just think it's a tool that we need to be using more and more. But again, we got to use it in terms of the patient care, that we're really utilizing it to make sure we're finding the right candidates. But I think the other thing that's important is that we're just sharing information between the different team members, and I think that's a message we got to come across.
Okay, wonderful. Everybody is unmuted, and we do have a provider on the call. Elizabeth Becker, are you on the call?
Can you hear me?
Yep, we can hear you.
Yes, I have Dr. McElderry here with us. He's one of our family practice physicians, and he just wanted to add a few comments regarding the PDMP as well.
Yes, I've been a family physician here in Council for 22 years, and for 5 years I've been using the PDMP, and I just timed myself getting on the PDMP. It was 54 seconds for one patient, but anyway, so it's less than a minute. I find it helpful if you have a electronic record that allows outside websites. I have the PDMP on our Cerner, so I can just click on that, get onto the website right away and log in. If you've requested the patient before, it's very simple. You just have to put in the first 3 letters of their last name after you put in for a new request. And then you click the box that you're certifying that that's your patient, and then it pops right up. Then you have to click on the PDF file, and it's right there. So it's helpful for a patient that you're considering prescribing for the first time for opioids or following your chronic pain patient. So just a quick comment about the Narcan. With our health system, we've just approved a opioid policy last month, and we're making Narcan prescriptions mandatory for anyone that's receiving 90 milligram equivalents of morphine, or if they're 50 milligrams or more, along with the benzodiazepine, that they should strongly be advised to have a Narcan available. And I think improving the amount of Narcan available in the community for those high-risk patients will help.
Thank you. Donna?
Wonderful. Thank you for those comments. That goes right along with the CMS guidelines for prescribing, and you will also find that resource on Innovation. We're getting a lot of questions about wanting some education. This will be recorded, and this will be put on Innovation within the next 3 to 5 business days. What Dr. McDonough did share today is a training material that also I will put on Innovation, so you can have that. And then also somebody's asking, would you be able to share your opioid policy and naloxone prescribing policy? And that's to you, Elizabeth.
Is that something?
I think I think most definitely we're kind of initially rolling this out, so I'll have to check with our medical executive committee. But at some point, I think it's very helpful to share what we're all doing. I developed a chronic pain checklist and did rolled it out in our clinic about 4 years ago, and we were able to substantially decrease the chronic pain opioid prescribing that we were doing in our clinic, and get them into addiction specialists or wean them off opioids when appropriate. So, I think this is an ongoing thing that we need to continue to share what we're each doing and try to learn from each other.
I think that's wonderful. And even if things are in draft forms, you could put draft across the top, that this is not implemented yet. But I think it is essential that we are sharing all these documents, because everybody's looking at doing the same thing. And then if somebody says, okay, I took that draft and I implemented this, and someone else says, great, I like that, someone else doesn't, we still have to remember that we are not dictating what to do. But we're all sharing resources moving forward. So anybody that is on Innovation, if you can share your resources, or if you're looking for a document, ask. And maybe that facility can put it out. But what I do ask is that you share to all, not to just single facilities, because we want to move forward as participants in this project together. Thank you so much to all of the speakers. I know that we're going over, and I just have a few more things to share with you, but one of the survey questions that we asked is, what other pain treatment options do you have? Do you offer patients? Not limited to. You can see that we did have mostly Tylenol or anti-inflammatories. What IHC is offering to you, we did make a comfort menu with a graphic artist. We will have to you in the next week interventions that you can choose to put under each of these. You can also insert your hospital name and logo in. This is something that we are currently getting a list of. We are making 3 different menus. One looks like this that you can laminate and put at the bedside for the inpatient. And then you can go ahead and take the same template and laminate one for your ED, because those measures will look different. But what we are developing is a tri-fold handout for your patients to take home on discharge, and we've heard that twice today, to make sure when patients are going home that they do have interventions that they can repeat at home. So this is something that you'll be seeing in the next week. The next thing that I wanted to show you is, do you know where the medication drop-off for opioids is in your area? We did create these 2 resources and did send them out to you. I'm very excited to tell you that we've had a lot of people say that they are giving these over to their clinics. You have a choice of using the first one or the second one. The first one is for sure for your ED and for your providers to use. But if you would like the treatment facilities to be present on your patient handout at discharge, you certainly can use these. We did just put a statement at the top, opioid resources for which hospital. We are just using this as an example. If you would like to have your hospital logo up there, please contact Stacy and she will get that done and sent out to you. Just a couple more slides here. Our community meeting facts. The title is Moving Upstream to Conquer the Opioid Crisis. The purpose is to educate your community on the safe and effective use of opioids and get them to participate in their opioid discharge care plans. As we were talking about with the Joint Commission, it does show and ask that patients and families be involved in these care plans. You can schedule these during the day or evening during the week. We will be your guest speakers. Our presentation is about an hour long and does include roundtable discussions. That does include patient participation. Participants will open and close the meeting. Once again, these slides will be available online in the next 3 to 5 business days, but this is just going through the commitment to participate. Our offers to you are large. Quality improvement consultation, virtual and on-site visits, community education on the safe and effective use of opioids, national recognition. We are the only place in the entire nation that is working on this at this point, and we are already getting a lot of national recognition. The hosting participant will do, or the hosting cohort, so that's us, will do the data analysis and provide evidence-based practices as we are moving forward. So again, the list of benefits are narcotic drop-off sites and treatment facilities in your county, our comfort menu template, sharing of successes, peer support, community outreach, and then coaching from our expert pharmacists. Our action items for success, and I promise you this is our last slide, data, data, data. Make sure that you're reporting that data so we can show the improvement. Form your opioid guardianship team and make sure that you have the right people around the table for these groundbreaking interventions. Teamwork on the treatment plan. Join and participate on innovation. This is a must, and like I said, we'll get that rolling hopefully in the next week. Schedule community meetings. Schedule your coaching time with Brian, Randy, or Jennifer. You will get a schedule out here in the next week that will give you some options for dates and times. Get your comfort measure laminated, or your comfort menu laminated and at every patient bedside. And of course, give your patients discharge on opioids, the drop-off comfort menu, and Naloxone access. Our next webinar is September 21st. This gives us a lot of working time, and we look forward to meeting with you. 2 months, we should be going full steam ahead. We hope to have some great success stories on this next webinar. And once again, I'm so sorry that we have gone over, but this is important business, and I think the interest is high. So without further ado, Brian, do you have any closing comments here?
Yeah, just want to say, please utilize this opportunity for these calls, even the 15 or 20 minutes with yourself and or your team. We can really work together and brainstorm and help you accelerate your progress. So thank you, Jennifer. Good job.
Okay. All right, everybody have a great day and a great weekend, and I look forward. I will be sending out an email in the next 2 business days with a lot of offers, a lot of information, and if you can think of anything that we can do to support you with resources, please let us know. So once again, thank you.